A warm welcome to today's class. Today I'll be talking about aortic stenosis. Okay. As I told you earlier, stenosis means narrowing of the valve. So in aortic stenosis, there is narrowing of the left ventricular output, the aortic valve. Now, what are all the causes of aortic stenosis? We can divide the causes depending on the age. Okay, less than 30, 30 to 60, and more than 60 years. Okay, if it is less than 30, we have to think of unicommissural valve. Unicommissural valve, usually you have 3 leaflets, but in unicommissural there is only 1 leaflet doing the work of 3. So less than 30 is unicommissural. Apart from that, another condition is rheumatic heart disease. In rheumatic heart disease, the isolated aortic valve involvement will be very rare. You will always have associated mitral valve abnormalities also. 30 to 60, think of bicuspid. The commonest cause of aortic stenosis across the age group is bicuspid aortic valve, where the 2 valve leaflets does the function of 3 valve leaflets, because of which there will be wear and tear, and that will cause stenosis. More than 60, it is atherosclerotic. Atherosclerotic is the common cause of aortic stenosis in patients more than 60 years of age. So these are the 3 important causes of aortic stenosis. Now, what happens in aortic stenosis? There is obstruction to the LV outflow, because of which the systolic pressure gradient between the LV and the aorta will increase. That will cause, when the left blood enters into the left ventricle through the left atrium, and it is pumped out through the left ventricle. This is a stenotic valve. Normal size of the aortic valve is about 3 centimeter. It gets reduced to 1.5, it is moderate. Less than 1 is 1.5 is mild. Less than 1 is moderate. Less than 0.75 is severe. Okay, so what happens? There is a resistance to the left ventricular outflow. In order to overcome this stenotic valve, the left ventricle will hypertrophy. There is pressure overload in the left ventricle. To overcome that, there will be concentric hypertrophy of the left ventricle. Okay. Once this left ventricle hypertrophies, what happens is that the compliance is going to be reduced. So once the compliance is reduced, the left atrium will find it difficult to empty the blood. So there will be a back pressure, and the back pressure will be reflected in the lungs. Lungs will go to the right ventricle, right atrium, and the systemic circulation. That is how the hemodynamic changes takes place in aortic stenosis. What symptoms will these patients with aortic stenosis have? There is 3 cardinal symptoms of aortic stenosis: chest pain, syncope, breathlessness. Okay. Why chest pain? There is a concentric hypertrophy of the left ventricle. The epicardial vessels will find it difficult to reach the inner part of the ventricle because of the increased muscle mass, and the perforation of the epicardial vessel will not be proper. Secondly, there is decreased output in the aorta. So the coronaries will be compromised. Because of the hypertrophy, there will be increased demand. The supply is reduced, so you'll have angina. Chest pain is common. Secondly, syncope. Why syncope? Because I told you there is narrowing of the aortic valve, so the output is reduced. If there is tachycardia, if the patient goes in for arrhythmia, the heart rate increases, so the left ventricular output is going to be reduced. When you exercise, there will be peripheral vasodilatation. Okay, and that will be compensated by increased cardiac output in a normal heart. Whereas here, in aortic stenosis, there is a fixed cardiac output, because of which the peripheries, the cerebral circulation will be compromised, and the patient will develop syncope. So second symptom is syncope. Okay. Thirdly, the patient will develop dyspnea on exertion because of the cardiac failure. I told you there is hypertrophied left ventricle, back pressure, lung congestion, that will cause dyspnea on exertion. What we have to remember is that once the patient develops symptoms, the prognosis or the days are numbered. Okay, anybody with angina pectoris in a patient with aortic stenosis, the 5-year survival is less than 50%. Okay, anybody with angina. Anybody with syncope, the 5-year survival is, the 3-year survival is less than 50%. So 50% of the patients with syncope and aortic stenosis will die in 3 years. They develop exertional dyspnea or cardiac failure, the 2-year survival is less than 50%. So what this means is that any aortic stenotic patient who are symptomatic needs to be operated. They have to undergo valve replacement. Otherwise, one important complication of aortic stenosis is sudden cardiac death. See what happens, there's so much of stenosis, when you exercise, hardly any blood goes out. Okay, if there is no cardiac output, the heart will go in for arrhythmia and the patient can develop sudden cardiac death. That's an important dreaded complication of aortic stenosis. So that again tells you that the patient needs to undergo a valve replacement once they become symptomatic. Okay, how do you diagnose clinically? What are all the features of aortic stenosis? Starting from pulse. The left ventricular output is reduced, so you'll have a small volume pulse. In aortic stenosis, you will have pulses parvus et tardus. If you palpate the carotid, it will be the beat will be slow and late. It's called parvus et tardus. Systolic BP will be reduced. BP will be reduced. There will be systolic decapitation. Secondly, the pulse pressure will be narrow. Unlike in aortic regurgitation, you have wide pulse pressure. Normally, you have a BP of about say 120, 70, 120 over 70, 120 over 80. Here in aortic stenosis, it will be like 110 over 90. You will have a narrow pulse pressure. That is because of the aortic stenosis. Okay, BP. Then what happens to the JVP? JVP will be elevated when the patient goes in for right heart failure. That's a long-standing aortic stenosis. You'll have that. Precordium, the apex beat will be initially in the normal position because of the concentric hypertrophy. Once it dilates, it can be shifted down or out. Initially, it will be in the fifth intercostal space, and you will have a heaving type of apex beat because of the pressure overload. You have pressure overload, so you have heaving apex beat. Okay, sustained. You can have in the second in the aortic area, you may have a systolic thrill, and it can be conducted to the carotid. So these are the findings in the precordium. And auscultation, what you have is that in the aortic area, you may have an ejection click because of the sudden opening of the aortic valve, followed by an ejection systolic murmur. Ejection systolic murmur is a diamond shaped crescendo decrescendo murmur. Why you have a crescendo decrescendo murmur, not a holosystolic murmur? Because see, if you take the cardiac cycle, when you have systole I mean left ventricular systole, it contracts, the mitral valve closes, and it will take a few milliseconds for the aortic valve to open because the left ventricular pressure has to overcome the aortic pressure. So it doesn't happen immediately during systole. A few milliseconds after systole, there's opening of the aortic valve. It can cause a click, which is, if it is pliable, followed by, see, the blood the LV is contracting and the blood is pushed up. So you will have an upstroke in the murmur. And later on, slowly this ventricle will begin to dilate. So the output is going to be reduced. So you'll have a down crescendo. So you will have a crescendo, decrescendo, ejection systolic murmur. And it can be conducted to the carotid. Most of the time it will be conducted to the carotid also. These are the findings by which you can diagnose aortic stenosis. Okay. Now what investigation can we do? Apart from the routine, you will have to do ECG. What we'll see in the ECG? Left ventricular hypertrophy. Later on, you will have cardiomegaly. Left ventricular hypertrophy will be seen in the ECG. If the patient goes in for atrial fibrillation because of the left atrial dilatation, that will be reflected in the ECG. X-ray chest, cardiomegaly, calcification of the aortic valve can be seen, and if the patient goes in for pulmonary edema, all the findings of pulmonary edema like curly A, curly B lines, prominent upper lobe veins, bilateral alveolar shadow, right pleural effusion, all will be seen in the chest X-ray. Finally, you confirm by doing a echo. The valve gradient is important because that will tell you when to operate. As I told you, the normal valve size is 3, and once it is severe, you have to operate, and once the patient becomes symptomatic, you have to operate. Medical management, there are certain drugs which you need to avoid in a patient with aortic stenosis, and vasodilators should be avoided because of the fixed cardiac output. But generally, to treat initially failure, you can use ACE inhibitor and beta blockers. NTG can be used to relieve angina, but always be cautious while using nitroglycerin because it can cause vasodilatation. Cardiac output may be reduced, so that you will have to balance it. Statins are useful because the basic pathology in aortic stenosis is atherosclerosis, which is similar to the coronary artery disease. So statins will help. But once, as I told you, the patient becomes symptomatic, always replace. You can do a valvotomy, but that is not long lasting. So replace valve. What valve to replace? Bioprosthetic or mechanical? It depends on the age and the survival, how much the patient you are expecting to survive. See, if you use a bioprosthetic valve, there is no need for anticoagulation. That's the advantage of bioprosthetic valve. But the thing is, it will not last for more than 10 years. So if the patient is young and if you feel the patient is going to last for more than 10 years, always use a mechanical valve. But in a mechanical valve, you will have to give anticoagulation. Warfarin is the standard of care that has to be given, and the INR has to be maintained between 2 to 3. That is the target INR. One important complication, always remember that these patients can go in for sudden cardiac death. So I'll be happy if you remember that these patients, when they become symptomatic, will need valve replacement. Thank you.